pleasure to introduce Natalie Staplin from UK. And you will discuss SGLT2 inhibitors in different patient groups and the effects on chronic kidney disease progression.
Thank you very much, and thank you for the invitation to speak at today's symposium. So just before I start, I've got a few disclosures. So most of the results I'm going to show you are from the EMPA-KIDNEY trial, which was initiated by the University of Oxford, who led its design, conduct and analysis and reporting, but the trial was funded and sponsored by Boehringer Ingelheim. And I should just disclose, I also get financial support for other trials from Eli Lilly and Novo Nordisk. And we have a long-standing departmental policy to decline honoraria for any talks that we give. So to outline my presentation today, I'll give a brief recap of the EMPA-KIDNEY main results, although Beatrice gave you a lovely summary of those, so I won't spend too long on that. I'll also mention the collaborative meta-analysis of large SGLT2 trials, particularly focusing on how the kidney outcomes differed by diabetes status. And then the final section of the talk is some new secondary analyses that we've done of EMPA-KIDNEY, looking at the effect of empagliflozin on progression of kidney disease in different patient groups. So, as has already been mentioned, EMPA-KIDNEY was designed to assess the effects of SGLT2 inhibition in a broad range of patients with CKD. They were randomized to either empagliflozin 10 milligrams once daily or a matching placebo after the investigator had judged that they were on a clinically appropriate level of RAS blockade. And the primary outcome for EMPA-KIDNEY was cardiovascular death or CKD progression, where progression was defined as either reaching end-stage kidney disease, so that could be dialysis, kidney transplant, and we also included renal death in that definition, or a sustained eGFR decline of 40%, or a decline in eGFR to less than 10 millimeters per minute. The EMPA-KIDNEY was an event-driven trial, so the intention was to continue until 1,070 primary outcomes had accrued, but the Data Monitoring Committee actually stopped the trial early for efficacy a few months before we would have met that particular target. So the baseline characteristics, people were on average about 64 years old at randomization, and we only had about a third of female participants in the study. We had just over half of them having no prior diabetes. And in terms of eGFR, it was one of the lowest levels of eGFR in any of the SGLT2 inhibitor trials studied, with a mean of around 37 milliliters per minute, and we had about a third with an eGFR less than 30 at randomization. And in terms of UACR, we had quite a broad range of criteria for that, with about half of the participants having a UACR less than 300 at randomization, and also a wide range of causes of chronic kidney disease, with 70% having non-diabetic causes of kidney disease. So we already know how well EMPA-KIDNEY, empagliflozin works for preventing CKD progression. The levels of cardiovascular death were a lot lower in the trial than we anticipated. So the majority of the outcomes in this primary outcome were cardiovascular disease progression events. And as I'm talking about the effects in different types of participants, I'll take you through some of the subgroup analyses that we did. So we pre-specified three key subgroup analyses: by diabetes, eGFR, and UACR. So when we looked by diabetes, there was no evidence of a difference in the effect of empagliflozin. Also, we saw no effect when we looked by kidney function. So this was the pre-specified subgroup groupings that we had used of less than 30, 30 to 45, and greater than 45. But we actually had slightly more people with an eGFR less than 20 at randomization than we anticipated. So we did also do a post hoc subgroup analysis where we split out that bottom group even further, and reassuringly, even in people who had an eGFR less than 20 at randomization, we still were seeing effects that were consistent with all of the other participants in the trial. And then we come to the subgroup analysis by UACR. And this is the one that has probably had the most discussion, I think, because it does suggest that perhaps there may be less effect in the people with lower levels of albuminuria. The p-value for trend here is only 0.02, so it's not a strong evidence, but it does suggest that maybe it doesn't work quite as well in people with low levels of albuminuria. But by the end of my talk, hopefully, we'll have got further data that explores that to reassure you of the benefits of using it in this particular group. So at the same time as writing up the EMPA-KIDNEY main results paper, we were also working on a meta-analysis with the SMART-C consortium, where we wanted to look at kidney outcomes by diabetes status, as that was really the main question that still remained to be answered at that time. And so you've already seen this slide, which I also borrowed from Dr. Will Harrington, one of my collaborators in Oxford, showing all of the SGLT2 inhibitor trials, and these were all included in the meta-analysis that we conducted, so that we were looking at the totality of the evidence across all of the trials that had been conducted at that time point. The main issue that we had with this was that if you looked individually at the 4 renal trials, the kidney disease progression outcomes that have been defined for each of the trials were slightly different. So doing direct comparisons across the trials of the different kidney disease progression outcomes were challenging, because some used doubling of serum creatinine, like Credence. DAPA-CKD and SCORED had used a 50% decline, but in EMPA-KIDNEY we'd used a 40% decline. So part of what we did in the meta-analysis was to come up with a common composite kidney disease progression outcome, so that we were comparing the same outcome across all of the 13 trials. And our main aim was to compare the findings in people with and without diabetes to see if it was equally as effective in those without diabetes. And we also wanted to look at whether there was any effect modification by primary kidney diagnosis, although for obvious reasons this was just restricted to the CKD trials. And we also wanted to look at the absolute benefits and harms in people with and without diabetes. So the outcome definition that we used in this meta-analysis was a sustained 50% eGFR decline from randomization, as well as a starting maintenance dialysis or kidney transplant, or having a sustained low eGFR. And that was either 10 or 15, as had been pre-specified in the individual trials. And again, we included death from kidney failure in this definition. So to give you a broad idea of the characteristics of the 13 trials when you put them all together, there's 3 main populations that have been studied: the type 2 diabetes and high risk, high cardiovascular risk, heart failure, and then chronic kidney disease. And as you would expect, in chronic kidney disease, the eGFR is much lower than in the other studied populations. And there's a range of amounts of people with diabetes that have been studied. So in the heart failure trials, half of the people studied have had diabetes. And in the chronic kidney disease trials, about 20% of the people studied have not had diabetes. So when we look in total across all of the trials, we're looking at about 16,000 people without diabetes that have been studied out of a total of 90,000 people. So you've already seen this slide, but just to show that when you look overall, there is a 37% relative risk reduction in this kidney disease progression outcome. And when we look by diabetes status, there's no evidence to suggest that the treatment effects are different in those without diabetes, even accounting for the fact that we have a little more uncertainty about the effect size in the no diabetes category due to the lower numbers of people that have been studied there. And when we look by kidney disease progression and by diagnosis of chronic kidney disease, so for Credence and SCORED, we just assumed that all people in there had diabetic kidney disease. And for DAPA, CKD, and EMPA-KIDNEY, we were able to split out into further categories, including ischemic and hypertensive kidney disease, glomerulonephritis, and then other diagnoses. And when we look at the heterogeneity across these different categories, we didn't see any evidence the size of the effects differs by type of chronic kidney disease diagnosis. And reassuringly, when we then further split out the GN category into IgA nephropathy and FSGS, again, we didn't see any evidence that the size of the effects was differing there. And we saw some very nice and very clear effects in IgA nephropathy with EMPA-KIDNEY backing up the results that had been already seen in DAPA-CKD in this group. And so I'll just take a moment to talk you through the plots on these slides, because they do take a moment just to digest. So on the y-axis here, you have the number of events that are either avoided or caused for every 1,000 patients that you would treat with SGLT2 for a year. And we calculated these absolute risks by taking the overall relative risk that we saw across all of the trials and applying them to the rates that we saw in the placebo arms. So if we take the average rate across all of the placebo arms of all of the trials, what rate do we get? And that's what you see stated across the top of the plot. And so doing this, we can see that for people who've got CKD and diabetes, you can prevent about 11 kidney disease progression events for every 1,000 people that you treat for a year. And because of the inclusion criteria of the trials that had people with CKD without diabetes, we had a slightly lower eGFR in those people, so a slightly higher rate of progression, and then therefore we would avoid about 15 kidney disease progression events for every 1,000 patients treated with SGLT2 inhibitors for a year. But obviously SGLT2 inhibitors don't only work on kidney disease progression, so you can see that we would also prevent about 5 acute kidney injury events, regardless of whether people had diabetes or not. And for people, particularly with diabetes, we'd also prevent a lot of cardiovascular death or hospitalization for heart failure. So about 11 events in those with diabetes and only 2 events in the people without diabetes, just due to the much lower rate of cardiovascular disease in those without diabetes. But we also need to balance this against the potential risks of treatment. So the 2 safety outcomes that we decided to look at were ketoacidosis and lower limb amputation. And in people with diabetes, you would probably cause about 1 extra ketoacidosis event and 1 extra amputation for every 1,000 patients treated for a year. But in the people with CKD but without diabetes, because the risks of these particular side effects are so low, we didn't have the number of ketoacidosis events was so small that we couldn't even estimate a relative risk for it. You would actually not increase the risk of those particular safety outcomes at all in people without diabetes. So the conclusions from this meta-analysis are that in the study populations, SGLT2 inhibitors safely reduce the risk of kidney disease progression, irrespective of whether people have diabetes, and also these benefits don't appear to be modified by kidney disease diagnosis, and the absolute benefits far outweigh any harms that you have in patients with CKD. And so now I'll move on to the final part of the talk, which is the secondary analyses of EMPA-KIDNEY that I mentioned earlier. So these secondary analyses focus on eGFR slope analyses, which was one of the tertiary efficacy outcomes that we had in EMPA-KIDNEY. And we had 2 ways of defining the slope that we included in EMPA-KIDNEY. So the first was the total slope, which is where we take all of the eGFR measurements from baseline to the patient's last scheduled visit. So you can see in this graphic on the right-hand side of the slide, it's taking eGFR measurements at all time points. But we also define the chronic slope, as we think this is a more appropriate measure for thinking about long-term progression of CKD. And in EMPA-KIDNEY, that was defined as all of the eGFR measurements from the 2nd month visit up until the last scheduled visit. So you can see here on the graphic on the slide that we're not using the baseline value, and so every eGFR measurement from 2 months onwards is used to define the chronic slope. And the reason for looking at slopes here is that it does offer greater discrimination versus the binary clinical outcomes that we've been looking at so far. And it is an accepted surrogate outcome for CKD progression. And to help you put the results I'm about to show you into context, a eGFR slope reduction between 0.5 to 1 millimole per minute per year would be considered to be clinically relevant. So when I show you the absolute effects of empagliflozin on chronic slope in EMPA-KIDNEY in a moment, just keep those numbers in mind. So when we looked at the chronic slopes overall in EMPA-KIDNEY, in the placebo arm we had a rate of change of minus 2.75 millimeters per minute per year in the placebo arm, and in the empagliflozin arm, which is shown in pink on the slide, that reduced down to minus 1.37 millimoles per minute per year. So that's an absolute difference of 1.37, or a 50% reduction in the chronic slope when we give these people empagliflozin. And so the pre-specified analyses that we had was to take these slope analyses and do them in our key subgroups that I mentioned at the beginning of the talk. So we can then compare what we see in the chronic slope analyses with what we saw for the clinical outcomes in these key subgroups. So I'll just quickly run you through the methods we used in these analyses. We pre-specified that we would use shared parameter models to estimate the chronic slopes. So I won't go into too much of the statistical details. I'm a statistician, so if you're interested, come chat to me after and I'll go on about them for quite a while. But the benefits of using these models is that they take into account censoring when people go on to have end-stage kidney disease. So they're statistically the most appropriate way of estimating slopes in the population that's at such high risk of going on to renal replacement therapy. We had pre-specified that we would use absolute differences in the chronic slopes, that they would be presented for these subgroup analyses. But we realised when doing the analyses that it's actually really also important to look at the relative differences in each of these subgroups. And we calculated those by dividing the absolute effect and the 95% confidence interval that we had by the mean slope in the placebo group. And because we also had quite a lot of power in our lowest eGFR and highest UACR subgroups, we did some post hoc expanded subgroups where we split out those particular categories further. And we also subdivided diabetes status by diabetes type, because we did have both people with type 1 and type 2 diabetes in EMPA-KIDNEY, so we were able to look at those two particular groups separately as well. So the focus of these analyses was on the three key pre-specified subgroups, which are diabetes status, eGFR, and UACR, but we did also do analyses of a whole range of other subgroups, including primary kidney diagnosis, and I'll also summarise the results of those analyses as well. So I'll just run you through some additional baseline characteristics, because the three key subgroups are actually quite correlated with each other. So that's important for understanding the results that I'm about to show you. So in the looking at eGFR and UACR by diabetes status, in the people without diabetes, the mean eGFR was a little bit higher, but they also had much higher levels of UACR. And these are all just artifacts of the particular inclusion criteria that we had for EMPA-KIDNEY, where if you had an eGFR between 20 and 45, you could be included irrespective of your albuminuria. But if you had higher levels of eGFR, you needed to have high levels of albuminuria to be included. And then when we look at the level of diabetes and UACR by eGFR categories, you can see that in the lowest eGFR category, we have the highest levels of people with diabetes. Again, this is because this hadn't been as well studied in the other trials that had been conducted. So our low eGFR category included a lot more people with diabetes. But they still had relatively high levels of UACR. And slightly unexpectedly, our middle category had lower levels of UACR compared to the higher eGFR category. So these aren't perhaps necessarily going to capture all of the types of patients that you would see in clinic, but are just what happens with the particular inclusion criteria that we had. And then when we look at UACR and see how diabetes and eGFR vary across there, as UACR went up, eGFR went up, and we had lower levels of diabetes in the highest UACR category. So when we look at the absolute effects on chronic slope, so I'll start with the diabetes subgroup, we can see that in people who had diabetes, there's a higher absolute effect on the chronic slope, and the test for heterogeneity here is significant, suggesting that when you look at slopes which have a lot more discrimination than clinical outcomes, there is perhaps a slightly higher effect size in people with diabetes versus those without. And I'll show you the relative effects on the next slide. However, it doesn't change the results very much because, as you can see from the slide, the mean slope in the placebo arm for people with and without diabetes is almost identical. So the relative effects here are entirely consistent with what we see for the absolute effects on the chronic slope. And again, a significant difference when we look at the heterogeneity test. When we expand that out to looking at type 1 and type 2 diabetes separately, there's a lot of uncertainty in the type 1 category because we only had a small number of participants in this category, but we do still see a clear evidence of an effect, a beneficial effect in the people with type 1 diabetes that is consistent with what we saw in the type 2 diabetes category. And I'll show you the relative effects again, but this is entirely consistent with what we see when we look at the absolute effects as well. So looking at eGFR, and this is the expanded eGFR subgroup that splits out the bottom category into less than 20 and 20 to 30, what we actually again see a trend here with a suggestion that the people at the lowest levels have slightly less benefit compared to people at the higher categories. So this really does support what Beatrice was saying about starting people earlier in their CKD disease to try and get the best benefits for patients. And when we look at the relative effects, we don't again, we see a very similar trend, probably not quite as extreme as we saw on the absolute effects, but again, a suggestion that the people at the very lowest levels aren't getting quite as much of the benefit as those at the highest levels. And I'll now move on to the UACR subgroup, which is probably arguably the most interesting subgroup in this particular analysis. So you can see here that when we look at the absolute effects on our expanded UACR subgroup, that the absolute effects in the highest categories are by far much larger than those in the lowest categories. Although there is a very clear effect of benefit even in the very lowest category here, where we're looking at a UACR less than 30. I mentioned earlier in the talk that a reduction in chronic slope of between 0.5 and 1 millimole per meter per minute year would be considered clinically significant. And we have a reduction here in the less than 30 group of 0.76. So this definitely fits into that clinically significant effect size. And there's clear evidence of a benefit with the confidence interval being clearly not being anywhere near zero. But an important thing to point out here is that there's a huge disparity in the mean slopes in the placebo arm across the categories. So in the less than 30 category, the placebo arm only had a annual rate of minus 0.88 a year. So it's not possible for them to get the absolute size of effects that you're seeing in the greater than 2,000 category, where we have a mean slope in the placebo arm of minus 6. So if we look at this instead on a relative scale, then actually our interpretation of things changes a bit. When you look at the relative, so taking the absolute difference in slopes over the mean slope you have in the placebo arm, actually the people with the lowest UACRs are getting the greatest relative benefits. A reduction of about 86% in your chronic slope in the people with the lowest UACRs versus a relative reduction of about 30% in the highest category. And this, the trend across here is very highly significant, suggesting that there's good evidence that those in the lowest UACR categories they have the highest benefits when you look at the relative effects on chronic slope. And so we did the same analyses for primary kidney diagnosis, but here we don't see any significant differences. The HET tests on the slide are both clearly not significant. So here, if you're looking at different primary kidney diagnosis, the best effect size estimate to use is the one in all participants. So a difference in mean eGFR slopes of 1.37. And this doesn't change when we look on a relative scale. So again, if you're looking at different types of primary kidney diagnosis, on average, the best estimate to use is that one of all participants, so a 50% reduction in chronic slope, irrespective of people's primary kidney diagnosis. So I did say that we looked at lots of other subgroups, and there were 3 other subgroups where there was some evidence for effect modification in the relative differences in chronic slope. These were age, HbA1c, and 5-year risk of kidney failure. But I should point out that clear benefits remained in all of these subgroups. It was just that perhaps the size of the effect is slightly different in some of these subgroups. But these are also 3 subgroups that are clearly correlated with our other 3 key subgroups that we've been looking at. So it's quite likely that it is differences in either UACR, eGFR, or diabetes status across these categories that are explaining some of these this heterogeneity that we're seeing in these particular subgroups. And we also looked at sex, race, history of cardiovascular disease, blood pressure, BMI, NT-proBNP, and medication use. And in those subgroups, we saw no evidence of any effect modification. So again, the effects are consistent across those particular subgroups of participants. We did do a few sensitivity analyses. I have mentioned a few times how there's correlation between the 3 key subgroups that we had. So we were wondering if there was one particular subgroup that might be driving all of this heterogeneity. So we did some sensitivity analyses where we included interactions with other key subgroups into the models. And the results of these were essentially unchanged, suggesting that it's independent effects of each of the 3 key subgroups on the relative effects on chronic slope. And we also did analyses that were restricted just to on-treatment eGFR measurements, or we had central laboratory measurements that we used in our main analyses, but we also did some analyses using the locally measured creatinine values that we had. And again, those made no difference to the results, showing that these are fairly robust results that we're getting here. So the conclusions from this particular part of the talk: empagliflozin slowed the rate of progression of chronic kidney disease among all types of participants that we had in the EMPA-KIDNEY trial, including those with very little albuminuria. And so this is suggesting that patients at the lowest risk of CKD progression could benefit from treatment with SGLT2 inhibitors in terms of the preservation of their kidney function. In addition to obviously the other proven cardiovascular and mortality benefits that these drugs have. And if you would like further details on any of the analyses that I've just been showing you in this final part of the presentation, the full details are available in 2 companion papers that were published at the end of last year in the Lancet Diabetes and Endocrinology. And just a quick update. So what are we doing next in the EMPA-KIDNEY collaborative group? We've got post-trial follow-up, and the final follow-ups have just started, and we'll be locking the database in mid-July. So we hope to have, by the end of the year, results of an extra 2 years of follow-up. People weren't being treated with study treatment during that time, but we've got an additional 2 years of follow-up in the trial that we'll be hoping to have published by the end of the year. So hopefully that will be some more exciting results to share. And we've also got a lot of biomarker studies ongoing. We're measuring lots of things in both the serum and the urine. We've got tubular biomarkers in the urine, proteomics in both blood and the urine, and we're also getting genetics data. So again, hopefully there'll be lots more interesting results coming from the EMPA-KIDNEY collaborative group over the next few years. And I'd just like to say thank you, particularly to all of the participants in the trial, but also to all the people who were members of our committees, the staff working on the study, and everyone else who makes up the EMPA-KIDNEY collaborative group. Thank you.